So over the next year, as more people are getting tested, what I would hope happens is that we gather more data to figure out how to refine the risk assessment as well as the management guidelines. The other thing that's happened over the last few years is because the sequencing costs have plummeted so drastically, tumor testing, in addition to testing for inherited cancer risk, which is really germline testing, so testing in one's constitutional DNA, there's also tumor testing that occurs, which can also find mutations but that may predispose to inherited cancer risk, but you don't know if that's just a tumor-only mutation versus is it also present in the germline. So it raises the risk for a germline mutation that then needs to be confirmed in the germline. So with that, I think we are starting to get more people that we're identifying through tumor tests that then go forward with germline testing. The other thing is with treatment. Many years ago, when we were thinking about genetic testing, we were really refining risks rather than using this information at point of care during an active cancer diagnosis, whereas that's starting to change as well, where with BRCA, for example, we have used this information to guide surgical decisions. So if a woman has a BRCA mutation, they may choose a bilateral mastectomy versus a lumpectomy. With the development of targeted treatments like the PARP inhibitors, now at point of care, they may choose to, it may impact their medical treatment as well as their surgical treatment, and that's where the field is going with these other genes. Many of these genes are involved in the same pathways as the BRCA genes work. So it really could refine the medical treatment as well as the surgical treatment in the context of an active cancer diagnosis.